So our keynote speaker today is J Helman, and Lee is a tremendous addition. Gosh, I just keep getting in this thing gets in the way. But Lee, okay, so here's his bio. Lee Helman received his MD from the University of Maryland School of Medicine, magna cum laude, and was elected AOA, Alpha Omega Alpha. He completed his internship and residency in internal medicine at Barnes Hospital, Washington University. Dr. Helman completed training in medical oncology at the National Cancer Institute. He did his postdoctoral training in molecular genetics section at the pediatric branch at the NCI. He served as, the chief of the pediatric oncology branch from 1997 to 2007, and as a scientific director for clinical research in the Center of Cancer Research at the NCI from 2007 to 2016. He joined Children's Hospital LA and the University of Southern California in 2017, and as professor of pediatrics and medicine at the Keck School of Medicine and director of the basic and translational research within Children's Center for Cancer and Blood Diseases at CHLA. He was elected to the American Society of Clinical Investigation and the American Association of Physicians, and is a founding member and past president of the Connective Tissue Oncology Society. He received his 2011 ASCO Pediatric Oncology Award and is a fellow of ASCO. Dr. Helman was the inaugural chair of the Pediatric Oncology Group. He serves as the vice chair of a scientific advisory committee for Stand Up to Cancer, and is a scientific partner to the AACR. Dr. Helman's laboratory work focuses on the biology and treatment of rhabdomyosarcoma, Ewing sarcoma, osteosarcoma, and pediatric gastrointestinal stromal tumors. His major areas of research include the pathophysiological consequences of IGF signaling, identification of the molecular biochemical determinants of the biology of sarcomas, and the application of functional genomics to identify new treatment targets. And I can go on and on. But anyway, please welcome J Helman as our keynote speaker.
Well, let me start by thanking you, Jim, for a kind introduction. And I have to say, I have followed some tough speakers in my life, but Dan and Jackie, it's really hard to follow you. And I thank you, because I will tell you, we don't forget any of these kids. You help us remember what we're working for. Nobody needs to go through what you went through. We gotta stop. I'm sorry. So, you're gonna hear statistics, but we can never let this disease be a statistic. It's about Dave and every other Dave. Didn't mean to do this, I'm sorry. All right, I'm gonna get it together. So, I wanted to talk, and actually I should put I'm 40 minutes, I don't wanna be late, so let me put my alarm on. So, I'm very particular about that, and I don't wanna go over, so I'm going to put a 40-minute stop, so I'm respectful to everyone else since we're starting a little late, but here we go. So I wanted to talk first about a definition. You've heard AYA used already. A brief overview of the AYA sarcomas and the real progress we've made, but also the challenges we still face and where I see the future going. So you saw this number. In general, the definition that the NCI goes by is ages of 15 to 39. And I like to, and others, I break it into three categories. There's early young adults, which are 15 to 18, and these are by and large seen by pediatric oncologists. Although I have to say, 18-year-olds, it's a little hard for them to go on a ward with, 5-year-olds with leukemia. I know my own kids would have had trouble with that. And I will say, my 32-year-old was diagnosed as a resident in psychiatry with a pineal brain tumor Thank God he's doing okay, but so I have a real personal stake in this. The young adult I put, or others also, in the 19 to 24. And this is really, this is where you're transitioning, and they fall between the cracks, sometimes especially if they have a Ewing sarcoma or an osteo that we see in the pediatric setting, but a lot of medical oncologists don't see unless they go to a specialized center, and sometimes they don't go anywhere. And then there's the late young adults, which are in the 25 to 39. There are over 70,000 cases of what we call AYA cancer a year, but it's only 5% of all cancer because we know cancer is a disease of aging. So here I've listed the common AYA sarcomas, and you'll hear about some of these. I added, at the column on the left, desmoid tumor, and this is something I add because it's not considered a sarcoma. It's a tumor, and people often consider it to be not a malignancy, but it can kill people, and it's not uncommon in the AYA population. But you can see the others, and I'll come back to this. And you'll see many pictures of, whoops, see if I can get the pointer to work. You'll see many pictures, whoops, no, never mind. I can just use this. You'll see many, does this show there? Yeah, no, it's okay. You'll see pictures of these big masses. This happens to be in the pelvis. So this is a pie chart of sarcomas, since this is a meeting about sarcomas, and the percentage in the AYA population. And so the largest is this very odd tumor called dermatofibrosarcoma protuberans. How many of you have ever seen a case of this in the audience? Yeah, they're pretty rare, but they're common in AYA. And then you see the smattering of 10% leiomyosarcomas, rhabdomyosarcomas, synovial cell, Ewing's, liposarcoma, MPNSTs. So those are really the tumors that we deal with in general. Now here's something that I wanted. Now you saw I think it was 3% across the board. But this is an interesting, if you look here at the, if you look at the top is the males and the bottom is the females. Now if you go to the bottom lane, 40 and over, the bottom row is 80% of those are carcinomas. And you don't see many sarcomas. They're less than 2%, 1%. The sarcomas are in the box there. They're the blue and the greenish. You can't even find them in the adult population. But you can see as you go from, the AYA starting 15 to 19, it's 15% in males and okay.
This is the pointer here. And that's the
which is the
forward.
point? Okay, perfect.
Forward.
Thank you. Okay. So it's a large percentage, and it keeps getting smaller and smaller. Sarcomas in general get less and less common. In the pediatric population, they're very common. They're a big part of what we see as pediatric oncologists. So this is the problem that, and I apologize for my emotion here, but this was an older slide, but I don't think it's changed a lot. If you look at the improvement in 5-year survival by age group, the population that has been least impacted, 15 to 40, right? And there's many reasons for this, right? I mean, first of all, when you're 20, you think you're omnipotent. You don't believe you can get sick. You got your whole, there's also many issues about healthcare delivery and insurance, but this is why AYA is so important. We're not impacting, this is, as you said, these are people with their whole life in front of them. So this is what we need to keep in mind. Okay, so I've made the setting. Now I want to mention briefly that many of these sarcomas are set up by these chromosomal translocations. And this is just a listing of many of these. And you see the same tumors, right? Synovial sarcoma, Ewing sarcoma, alveolar rhabdomyosarcoma, desmoplastic small round cell tumor. We know what drives these tumors. These are specific alterations in the chromosomal topology. And the problem is almost every one of those are transcription factors, and they are, quote, undruggable. So we're just getting to the point of understanding and trying to develop drugs that target the driver of these, and it's been a really tough, hard journey. This is just another way of looking at it, and here you can see these are the adipocytic tumors. These are, liposarcomas. These are, remember I mentioned hematofibrosarcoma protuberans. It's also a translocation. This one is unique because this activates a kinase. And kinases are enzymes, and we can target enzymes. And we've had a drug that targets this. Fortunately, most patients can be cured with surgery, but if you need systemic therapy, we have systemic therapy for these now. But these others, you can see the Ewings, where we don't even know where it comes from, and the tumors of unknown. We don't know where they really come from, like synovial sarcoma, but they're driven by these translocations. Now, but we have developed, when we started the standard care therapy, and you'll hear about this afternoon, and you'll hear about it from some of our other speakers, it was chemotherapy. And you mentioned your son Dave was, got chemotherapy. That's what we had. But really, there's been a revolution in the last, and it started with imatinib, basically for CML. But you can see in the boxes here, starting at the top, sunitinib. We use this now for desmoid tumors, which I mentioned, and alveolar soft part sarcoma. I'm going to come back to that. So, it's a kinase inhibitor. Sorafenib is used in desmoid tumors, which I mentioned. IGF-1 receptor, I was involved in that, but it actually had some activity, but it's not been, we haven't figured out how to use it. Cediranib and pazopanib for both alveolar soft part sarcoma. So we have these new drugs that aren't chemotherapy, they're targeted therapies. So I'm going to just give you an example of desmoid tumors. Desmoid tumors are usually, they don't metastasize, so we consider them benign. But they can be, and they typically occur in young women, and they're miserable. They can make, they have, patients are on pain medicines. We all know about the opioid epidemic. They can ruin a young woman's life. And I can tell you, we used to treat these with non-steroidal anti-inflammatories, pain medicines, wait for the tumor, sometimes it burns out. So in the last 5 to 6 years, it's just been remarkable. First, there was a publication just this year in the New England Journal on sorafenib that actually had tumor responses where the tumors shrink. It was published in the New England Journal because we've never seen anything like this. And I got involved in this other drug called a gamma secretase inhibitor. We shall see the phase 2 trial was done. It was incredibly positive. Basically, 95% of the patients responded. And so the phase 3 registration study is going. So in 10 years, we have 2 drugs that we'll be able to use for treating a tumor that we didn't have available to us previously. Same thing, and alveolar soft part sarcoma to me was, I used to pimp the medical students because I would always say, well, what do you think the response rate is to alveolar soft part sarcoma? Because I was taught if it's low, you just say 15%. But when I saw a review of hundreds of patients treated over 25 years at MD Anderson, they said the response rate was 0. 0 is pretty bad, right? In the last few years, I was involved in this study on cediranib, which we saw some objective responses, pazopanib. So these are targeted therapies, and you really see alveolar soft part sarcomas responding for the first time. More importantly, I think you're going to hear a story of this in the cases. Immunotherapies, these checkpoint inhibitors, you've all heard about the explosion and the promise of immunotherapies, hasn't worked yet in sarcomas with few exceptions, which you'll hear a little bit about. But there was a study of a checkpoint inhibitor for sarcomas, and since alveolar soft part sarcoma is a sarcoma, it's really rare. But that was the only tumor that we saw responses, clear responses in a very early study. of checkpoint inhibitors. And man, this has changed. So it is now a tool that we have for treating alveolar soft part sarcoma that had a 0% response rate 10 years ago. So that's progress. Again, I talked already about these fusions and how difficult they are to target, but there are pathways, these other alterations, and GIST is a clear, after imatinib worked for CML, it was also found to work and really change the face of how we treat GIST tumors. But there are other targets that are becoming targetable, things like CDK4 amplification. So what's on the horizon? You know, we've had dramatic progress, but as I said, and as I unfortunately lost my cool a little bit, failure is unacceptable. It is unacceptable, and all of us that take care of patients, we live with every one of these. We remember every one of these young adults. It's tough. And also, the therapy is too toxic. You know that. I don't have to tell you that. That's not acceptable either. And one of our problems, I believe that progress is made through clinical trials, and one of our problems is there are small populations, and it's really hard to design a study well. But now let me really talk about the future. We used to think about cancer as this. It was these tumor cells. But we know tumor cells don't live in a vacuum or in a plastic dish. They really live in a neighborhood. So there's all these other cells we have to think about, and you're going to hear something about that. And we now have beginning to develop tools to understand that we got to think about the fibroblasts, the microenvironment, the blood vessels that feed the tumor, and we maybe can target some of these cells in addition to the tumor cells. Cancer is a complex foe, and we know now that they have to do a lot of things. They have to avoid the immune system. They have to avoid signals that say stop growing. So they have to sort of traverse all of these things. They have to evade the normal signals that tell them to die. They have to be able to metastasize. So there are many parts of this that we didn't used to think about before. And this is just expanding on that a little bit. And this was made popular by Hannah Weinberg back in the 1990s, and they've updated it. But now we have immune checkpoint inhibitors. We have telomerase inhibitors. We have these selective anti-inflammatory drugs, and on and on. So we're beginning to think of drugs that can target each part of this, not one thing, but a combination of things. And so again, I don't need to reiterate this. This just lists some of the targets across that are now available that target not just the tumors they were developed for, like breast cancer and colon cancer, but also selective sarcomas. But here's one take-home message, is that when we look at these signaling pathways, and I don't need any of you to understand this, I should put it up here because there's a lot of signals that go from the outside of a cell to the inside of a cell and tell it to grow. And we draw these as these arrows, these one-way arrows. But the problem is these pathways are all interconnected, and they're not one way. And so I just use it as an example, a very common pathway called the mTOR signaling pathway, and we use mTOR inhibitors in treating some of our patients now. The problem is we now know that if we block the mTOR pathway, you actually turn off a negative signal that blocks PI3 kinase signaling. So we didn't used to understand that it's not a one-way thing. So if you block this, you're going to activate this. So we got to think about combinations. We can't think about these growth factor pathways as one way. And that's because they're important for normal growth and differentiation. So they are incredibly interconnected. I don't know if you've ever gone into a closet of your the wiring for your internet, but it looks like that. These wires are just everywhere. So we can't think about it as a single pathway. So again, I want to emphasize a little bit the impact of clinical trials. We've identified new agents. We figured out how to use radiation therapy. We're doing much better with surgery, and we're getting better and better at pathology. But we get to do this by entering patients on clinical trials, and that's another problem with our AYA population. They're the least represented in clinical trials. Key components are multi-agent chemotherapy. Again, we knew that for a long time, but with targeted therapies, we kind of forgot that. Now we're using multi-agent targeted therapies, but less in sarcomas, and we need to do this. Treatment on clinical trials and risk-adapted therapy. This is an example of rhabdomyosarcoma, where you see the progress from the 1960s through the 1990s, and basically, survival rates have more than tripled. Now, obviously, we're lucky in pediatric cancer because these are mainly due to better chemotherapy. But the most important thing is we've developed risk-adapted therapy, and we've learned who's high risk, who's low risk, who's intermediate risk, and we know now we can't treat them all the same. That's one thing, is risk. And so another thing I just want to point out, and this is kind of using some work, my own work in the laboratory, but here was a study with this IGF-1 receptor antibody. These are all patients who had incredible responses to a single agent. 19 patients responded. But look at, most of these had already recurred within 18 weeks. So even though they had amazing responses, it was very short-lived. So we need to understand, and the reason they're short-lived, and this just shows you, these were not subtle responses. This is a patient with a Ewing sarcoma with these big lung metastases, and you can see, many of these tumors in the lung were just gone. It was a dramatic, with just a single drug, but they weren't long-lived. And the reason they weren't long-lived is that when we blocked the IGF-1 receptor, we activated Src kinase signaling, and we demonstrated this, we published this, and we went back to our our xenograft models, our mouse models, did exactly the same thing. We treated them, they went away, but they always came back. So it shouldn't have been a surprise. But now when we block the Src kinase, for the first time we're seeing cures in our xenografts. So there's actually a study now combining an IGF-1 receptor with a Src kinase receptor, with a Src kinase inhibitor. Immunotherapy. It's made it's the headlines in the newspapers So here's an interesting thing that I believe we can learn from history. So there was this guy, William Coley, who was the head of the bone tumor service at Memorial Sloan Kettering. And he developed these things called Coley's toxins. And patients responded, but the most common group of patients that responded were bone and soft tissue sarcomas. So back in the 19th century, we were already seeing that some sarcomas could respond to immunotherapy. We don't understand it, but it gives us room to be optimistic. And I just mentioned to you this alveolar soft part sarcoma, and now we know responds to checkpoint inhibitors. So here was a paper that just came out a year ago in the Oncologist, something old, Coley's toxins. And so we're beginning to rethink about this. Now, besides these checkpoint inhibitors, there are cellular therapies, and you've all heard of CAR T cells. In our field, in pediatric ALL, it's been revolutionary. We've been able to see patients who were sent home for hospice care respond to these adoptive cell therapies or these CAR T cells. I don't want to belabor this. There's a difference between a CAR T cell that is an engineered cell that can recognize any tumor independent of its HLA status, as opposed to a T cell that has to recognize a tumor antigen in the context of HLA. I just want to make that distinction. So we haven't seen CAR T cells work in sarcomas. That's these cells, which is kind of too bad because they recognize independent of whatever your HLA or your HLA type is. But these cells we have seen responses. This is a patient with synovial sarcoma. I'm sorry it's blurry, but you can see these pulmonary nodules disappear just with these CAR T cells. Again, the problem has been the longest response I've personally seen is about a year. All of these patients recur. So we need to learn how to combine these and better understand them. But they work. They work in a sarcoma, and I think we're going to we just need to do more work, keep figuring it out. So the identification of molecular alterations in sarcomas is leading, already has led to novel therapeutic options. It's likely, as I tried to say, as with chemotherapy, combinations of targeted agents have to be used. And I like to say, we figured out in the 1960s that nobody gives a single chemotherapeutic agent. But for 10 years, once we develop targeted therapies, we try to do a single therapy, and that's just fool's play. And that's because cancer is complicated. We know now that there are opportunities for immunotherapy in these sarcomas. And because some of these are so rare, we need to come up with novel therapeutic trial designs. Cancer is a disease of the genome, we know that. And I think there's a whole paradigm shift. And that is we're moving from reactive, we treat a patient, we wait for them to recur, and then we treat them again. We're now proactive. We can identify recurrence earlier. We're trying to use the patient's own tumor, precision or personalized medicine. We're trying to address resistance, and we also need to improve quality of life. And all of this is going to be done through research. So we're really using predictive medicine. And this is sort of the paradigm. We say one patient, one disease, but if we look at why do only 2 out of these 7 patients respond, we can identify this now molecularly. Here's an example from a colleague of mine when I was at the NCI loosed out. So these are patients with lymphoma. These are not Hodgkin's. These are another kind of lymphoma. But these look exactly the same. But when we look at their gene expression profile, this tumor is completely different in the genes that's turned on than this tumor. And this is called a germinal sentinel, and this is called an activated B. And they respond differently, totally differently, and we need different drugs for these. So our hope in the future of individualized medicine is that we'll take a breast cancer that we used to call breast cancer, but we'll treat these 2 patients with treatment A, and we'll treat these patients, once we identify what they have, with a different treatment. So breast cancer isn't breast cancer, and prostate cancer isn't prostate cancer, and Hodgkin's disease isn't Hodgkin's disease. So that's our hope. So I'm going to end with, this was the editor of the Journal of Clinical Oncology, and he said, life was much simpler for the clinical investigator 30 years ago. We had 5 chemotherapeutic drugs, and we learned how to give them. It's really complicated now. And almost you have to be an expert in a particular signaling pathway as well as in the disease. It's really hard to keep up on all of this, which is why clinical trials and being at a major center, especially for a disease as rare as sarcomas, is so important. I hope I've convinced you sarcomas are not one disease. They have multiple molecular genotypes. Novel therapies are becoming more available. We have to get the right drug to the right population, and that sounds easier than it is. It is difficult. We have to figure out how to do trials, because imagine if we take a rare disease to start with and then find a molecular subtype that's 20% of that. And actually in my lab we found a subtype of osteosarcoma that probably occurs in 5% of patients. Well, if osteosarcoma is 350 cases a year, and now I can find a subset of 5%, how am I going to do a clinical trial? So we're going to have to face this. But you're going to hear a little bit more about this from Dr. Mascarenhas, who played a really pivotal role in getting this TRAC inhibitor, which you'll hear about, approved. My point of showing this slide is when you find the right target and you have a good drug, look at this. This is a tumor that didn't respond. And almost every patient that had this translocation has had an incredible response, even with a single agent, which I still don't understand why they respond so well to a single agent. But it works if you match a target to a drug and you have a target that you can develop a drug for. So we have a lot of work ahead of us. We have to accelerate getting new drugs to patients. We have to learn better how to conduct rationally based clinical trials. We have to integrate advanced technologies, use the information, standardized biospecimen collection and work with industry to facilitate and say, let's not get caught up. We got our kids and our young adults to get these drugs to them sooner. Let's not get caught up in, if we have a good combination, and Bristol Myers, you make this drug, and Pfizer, you make this drug. We're talking about people. We're talking about the future. So we got to do a better job at that. I mentioned just briefly immunotherapy. We know there's things like tolerance. We don't understand why some tumors are more immunogenic than others. We need to figure out how to regulate these T cells and make them last longer when they do cause response. And last but not least, and we always talk about cancer control, and I think it's really relevant for the AYA population, is better access. And again, it's our AYA population that participates the least in clinical trials. And David, you can talk about this better than I can. But this was John Niederhuber was one of the NCI directors when I was there, and this is a quote from him. Access to health care will be a greater barrier, a greater determinant of cancer mortality than scientific advances. And so we need both. So I hope you've learned a little something. I hope my intention was to breeze through this to set it up. I think we'll have a great discussion moving forward. Thank all of you for coming, and to Jackie and Dan, thank you guys so much. Thank you. God, I really breezed through it, so we got plenty of time.
So, thank you, Lee. We have about 5 minutes for questions. Please feel free to ask questions. This is a safe place. Ask any question. We have a very mixed audience here today. We have patients. We don't have all healthcare providers here or healthcare personnel here. So please ask any question of Lee. This is a safe place.
The only dumb question is the question you were afraid to ask. That's my attitude. Sure. Yeah, I'm sorry, can you repeat?
MRI. Okay. Cancer cell size should be almost 1 centimeter size in order to be detectable by MRI, etc. these days. Then, for osteosarcoma, Ewing sarcoma, or synovial sarcoma, etc., the cancer growth rate, cancer cell growth rate may be different. Do you have any idea how many years it may take before one single cancer cell becomes big enough, almost 1 centimeter size, in order to be detectable in the early stage these days?
Yeah, that's a really good question.
Is doubling cancer cell theory acceptable in general among the oncologists, or is just a theory and not realistic?
So it's a really good question. I could talk a whole hour on this. So to see something by imaging, we're better now with MR, but it's billions of cells before we can image it, as you just intimated. I would say the easy answer to your question in terms of how long do these sarcomas, most of these are pretty rapidly growing, so partly it depends on where it is before a patient gets symptoms. But in general, they're in months, not years. But occasionally we wonder about some of these tumors where a patient has said, I had a lump 5 years and I followed it, and these are usually lower grade, slower growing tumors. But in terms of my moving from reactive to proactive, there's a revolution going on called circulating tumor cells and even more cell-free or circulating tumor DNA. And it's been shown over and over again now in other more common tumors, colon cancer, breast cancer. We can detect cells when they're circulating in the blood months before we can detect a recurrence. So we are going to be able to detect these way before we can image them. The question is then, if we intervene earlier because we detect them earlier, will that allow us to salvage more patients? One of the big questions is, as you know, if you have 1 billion cells, there's more time to develop multiple mutations because we know cancers mutate at a more rapid rate. But it's interesting. It looks like we just had a grand rounds last Wednesday by one of the pathologists here at the Norris. When you do these modeling studies, it looks like most of these bad actors, the cells that we can't kill, they're there at the beginning. So it's not like when the tumor is bigger, it's harder to cure. So I think the same genetics are probably there at the very early stages. So if we can cure a big tumor, we'll be able to deal with it, and obviously it just takes less therapy. So I'm optimistic that one of the things that we can use is this new technology to identify single cells or hundreds or thousands of cells as opposed to billions of cells. And I truly believe, now it's going to take us 10 years, because first we have to prove that we can see them, and that predicts recurrence. Then we have to do a clinical study and say, okay, can intervention do anything? So each one of those has to be carefully studied, but I'm optimistic it's going to make a major impact.
There's a microphone on the side here.
Thank you. Hi, I'm a parent. My son had leukemia, but he's in remission. I have a question, because sometimes I follow the cancer research overseas, especially in Israel. So they send me an email that, because you subscribe to their newspaper and they send you emails, that they created a decoy RNA that you were mentioning, that it's really hard to target in the patient because the transcription, like a coding, decoding RNA, it's very difficult. So they're creating a decoy, or they created a decoy and they used it on the patients. So what is the difficulty of that? Like the U.S. is not equipped to do those kind of clinical trials, or what is the... No. So, thank you for that question. So the idea of decoys have been around for a long time, and it makes sense. The problem, and it's not that people aren't doing these studies, but I would just say there's a lot of things. If I had a penny for every mouse I cured with something like a decoy, I'd have houses everywhere in the world. It's a different thing once you get to a proof of concept, to the pharmacokinetics, to making sure you can get that decoy where it needs to be. Mm-hmm. The problem with a transcription factor, it's in the nucleus. It's not in the cytoplasm. It's really hard to get drugs into the nucleus, first of all. Second of all, how long do they last? So there's all kinds of issues. So they only can be studied in the presence of a clinical trial. Yeah, but tumor, they live on those kind of, like the RNA is like their supplier. It's like they supply them with all the protein that they need.
So they need to be tested. And so far as I'm aware, every trial of a decoy so far in clinical trial has not been successful. Doesn't mean we shouldn't keep trying. But the clinical trial is our final proving ground. And that's what's been so exciting about, we knew about CAR T cells 10 years before we got it into clinical trial. We were curing mice. For once, it actually worked in people, but many, many times it looks great and it fails, and then we have to figure out why.
So maybe one more question?
Thank you.
Thank you for the question.
Thank you for the talk. I love that slide with, like the breast and prostate, and they all had different colors. That I suspect as we go deeper and deeper into looking into these individual cancers, is that it's going to be every color in the rainbow. And I wonder, how do you envision developing clinical trials for deeply personalized medicine? Is it like one trial per person? Is it one giant trial for everybody?
Yeah, and we're struggling with this. I'm sure you've heard there's the idea of the N of 1 study. The N of 1 study. So there are certain, first of all, these pathways, and I put up one that pretty much shows, I'd say 70% of the pathways we know are important for growth and metastasis. So they tend to be redundant. We tend to see them across different tumor types. I think, and we're testing this now, one of the things that we will do is, rather than doing breast cancer studies, we will do, and we know this already, we'll do HER2-driven tumors. And so rather than using Herceptin, which blocks HER2 only for breast cancer, we know now it works in gastric cancer if you have amplification of HER2. So we're going to get better at doing studies, not just in a histology, but in a grouping them according to what their driver mutations are. Now, of course, in immunotherapy, it's a huge advantage because, there, if you can activate the immune system, it shouldn't matter either, depending on what you're activating it with. And that's why these checkpoint inhibitors have worked in melanoma and small cell and non-small cell lung cancer and bladder cancer, et cetera. So it depends on what the target is. But I think one of the answers is we're going to be treating not by histology, but by grouping patients that have a similar, and we're going to have to do international studies. There's no question about it.
Thank you.
Thank you, Lee.
Thank you.